Hi everyone, my name is Richa Gupta and I'm a third-year cardiology fellow at Vanderbilt University Medical Center. I'm going into advanced heart failure and transplant cardiology. I'm excited to share with you the second part of a two-part series. This one deals with therapies in COVID-19 and cardiovascular toxicities. Hi everyone and welcome back. In part one of this talk, we reviewed mechanisms of myocardial injury in COVID-19. In this second half, we'll review possible treatments under investigation and cardiovascular toxicities. The same disclaimers to this half of the talk apply, so the data are limited, patients are ill, and for clinical decision making, we'll have to rely on the information that we do have. The mainstay of therapies includes support and pharmacologics. In terms of support, this is support of the failing organ or organ systems, ARDS management with the ventilator, diuresis and inotropes for cardiogenic shock, renal replacement therapy for kidney failure. And then pharmacologic treatments still largely remain under investigation. These include antivirals, immune-modulators, and then a category that I call other, which includes agents like statins and convalescent plasma. So antivirals. The key thing here is to remember that many of these drugs have drug interactions, and that's not to say that we cannot use them. We just need to be aware of those interactions. Remdesivir is a drug that was developed for the treatment of Ebola, and it binds and inhibits the RNA-dependent RNA polymerase of the coronavirus. Observationally, it's been helpful in Chinese cases, but there has yet to be a clinical trial that shows benefit with the drug. These trials are ongoing both through the NIH and in China, and compassionate use for the drug is available in the United States from Gilead in patients with severe illness. The cardiovascular toxicities have yet to be reported. However, the main toxicity and exclusion criteria for the drug is liver injury, which we should be mindful of in our patients on statin therapy or our patients who develop acute liver injury in the setting of the virus. Lopinavir-ritonavir works by inhibiting RNA viral replication and, at least in vitro, has demonstrated synergy with ribavirin. Notably, it can cause QTc and PR prolongation and can interact with statins, antiarrhythmics, antiplatelets, and anticoagulants. So this is a drug that has actually been studied in a randomized controlled trial, which was published in the New England Journal a few weeks ago. The authors studied 199 patients who had to have objective hypoxia to be enrolled, and the primary endpoint was time to clinical improvement at 28 days. What they found was no significant difference in improvement in the treatment group versus control. Confidence intervals were wide. Several limitations of the trial have been pointed out, however. For one, these were sick patients being treated in the midst of a pandemic, and there is some question of whether a larger trial may have shown benefit to the drug, or if the drug would have had better efficacy if given earlier in the course of the illness, rather than waiting until the point at which the patients developed hypoxia. Let's move on to immune modulators. The antimalarials chloroquine and hydroxychloroquine I've put under the category of being immune modulators because in the traditional sense of the drug as used for treatment of lupus and other rheumatologic conditions, this is what they're considered. But when it comes to viral infection, their mechanism actually suggests that they have more of an antiviral function. So they block viral infection by increasing the pH required for viral cell fusion, and they interfere with glycosylation of cellular receptors. In terms of cardiovascular side effects, we know that long-term exposure to these drugs can result in cardiotoxicity or antimalarial cardiomyopathy, manifesting as arrhythmia, heart failure, and conduction disease, particularly in patients with pre-existing heart disease. Short-term use of the drug is less of a concern, but we really don't understand how much exposure someone who might be predisposed to developing a cardiomyopathy might need for that drug to act as a second hit and potentially cause heart failure. Via CYP2D6, these drugs can increase beta blocker and digoxin concentrations for our patients that are on these medications. And finally, these agents, particularly in combination with azithromycin, can be QT prolonging. In terms of data, there have been studies showing in vitro efficacy of hydroxychloroquine over chloroquine. There are ongoing randomized controlled trials in China and initiated by the WHO, and there was a small study in France that became popular in the media recently. after President Trump touted the results as having the chance to be, quote unquote, one of the biggest game changers, quote, in medicine. This study, however, was not a randomized controlled trial. 20 received hydroxychloroquine, of whom 6 were not responding to the drug after a day, and so those people received azithromycin. And this was compared against 16 controls that either A, refused to be on the drug, or B, came from a different center. The endpoint was viral load at day 6. And while the curve suggests that hydroxychloroquine cleared the virus better than placebo, and that those who received azithromycin did best, there were actually 6 patients in the treatment group for whom we have no follow-up data. 3 of them ended up in the ICU, in fact, because of severe illness, and 3 were just lost to follow-up. This study was followed by another out of China with 30 patients who did not improve with hydroxychloroquine therapy relative to placebo, so currently we don't have a lot of data to support its use. The utility of steroids is unclear and controversial. Where they've been used in case reports in series with COVID-19, they're generally used in short-term, 3 to 5 days duration, where there's rapid deterioration of oxygenation, excess inflammation, and infiltrates on lung imaging. These have not yet been studied in randomized trials. In our cardiac patients, we have to remember that steroids will interact with Coumadin, and then contraindications include GI bleeding, immunosuppressed states, low lymphocytes, and concomitant bacterial and fungal infections. This was a viewpoint published in The Lancet that summarizes evidence to date on coronavirus infections and steroids and maintains that we really have no evidence that steroids are beneficial here. In the retrospective series of COVID-19 that I presented in part 1, steroids for the most part in these series did not appear to show any clinical benefit, but they were typically given to the sickest patients to begin with, so any conclusions from that observational data will be really hard to extrapolate from. This is a summary of trials of steroids used in SARS and MERS, and as you can see, steroids had no clinical benefit, were actually associated with increased mortality in one meta-analysis of the flu, had a lot of complications, and even resulted in delayed clearance of viral RNA. And this might be because while steroids may suppress inflammation in the lung, they can also inhibit immune responses and pathogen clearance. Tousle ISAB is a drug particularly of interest in the COVID-19 infections where there's hyperinflammation with high levels of cytokine release, one of those cytokines being IL-6, which is what this drug inhibits. The dosing for cytokine release syndrome for CAR T-cell mediated toxicity is listed here. Caution will have to be used in patients with low ANC and platelets, and the drug is contraindicated in TB, GI perforation, demyelinating disease. The drug is also associated with hypertension and increased serum cholesterol levels, but has no known effect on QTc. There are ongoing randomized controlled trials, including this one in China, which is currently enrolling patients with high IL-6 and COVID-19 related pneumonia. But otherwise, we only have retrospective, non-controlled, small case series, such as this one out of China, where 21 patients with high IL-6 levels were treated with tocilizumab and had improvement in CRP, their fever curve, and their oxygen saturation. But again, this remains yet to be corroborated in trials. Anakinra is another agent that inhibits the cytokine IL-1 that sparked interest as it relates to COVID-19 associated hyperinflammation. So this drug didn't show mortality benefit in sepsis trials. However, in a subgroup analysis of a phase 3 randomized controlled trial published in 2016, where they looked specifically at patients who had hyperinflammation and HLH, they actually did show that there was survival benefit with the drug compared to similarly hyperinflamed HLH patients who just received placebo. So shown in the graph, the bottommost dotted line and the solid line above it represent the patients with HLH who received placebo or Anakinra respectively, showing greater survival in the Anakinra treated group. There was no difference, however, in outcomes in patients who did not have hyperinflammation or HLH. Those are the top 2 lines of the survival curve. So these studies beg the question that has yet to be answered of whether there's utility in checking these cytokine markers or even D-dimer to dictate therapy in COVID-19. No guidelines or data currently exist to guide a recommendation at this time. Another group of immune modulators being investigated are the Janus kinase inhibitors. These have similar contraindications to Tousle ISAB. What these drugs potentially do is twofold. So first, they inhibit JAK1 and JAK2, which interrupts cytokine signaling to attenuate inflammation. And then second, they can bind to these protein kinases that mediate endocytosis of the virus after it attaches to the ACE2 receptor, and potentially thus disrupt viral entry. There are other drugs like Interferon that, for the sake of time, I won't mention. They follow the same theme as the drugs that I've mentioned: minimal data, known cardiovascular toxicities, so I won't go into them here. But for reference, this is a useful table that was published in a JACC review that came out on March 17th on the cardiovascular considerations as they relate to COVID-19, and this can be referenced for more details. The data that we have on statin use mostly stems from use in ventilator-associated pneumonia and is a mixed bag, with one trial showing possible benefit in mortality reduction and another showing no benefit. There is some observational data in MERS that possibly supports its use. The jury is still out when it comes to COVID-19, as we don't have any data. As a rule, patients already on statins should continue them unless stopping or reducing the drug is indicated for a separate reason, for instance, for acute liver injury or for a drug-drug interaction. Convalescent plasma is also of great interest as a therapy. This is plasma with SARS-CoV-2 specific IgG antibody that has been obtained from patients who have actually recovered from COVID-19. Interestingly, convalescent plasma was used as a treatment in the 1918 flu pandemic. This past week, a case series of 5 critically ill patients with COVID-19 and ARDS was published, and each of these patients clinically improved and stabilized. But this is a 5-patient case series. We otherwise have no data to support this, and we need randomized controlled trials. On a final note of therapies, many have asked whether there's an impact of ACEARB on the upregulation of ACE2 receptors that the virus uses to attach. The bottom line is there is conflicting data on whether these drugs increase or have minimal effect on ACE2 levels. In murine models with experiments in SARS done in 2005, treatment with ACEARB was actually protective against ARDS by mitigating an increase in angiotensinogen, which results from downregulation of ACE2 when it binds the SARS-CoV spike protein. Because of the lack of evidence on their potential benefit or harm, for now, all major cardiology societies currently recommend against adding or stopping ACE-ARB or other RAS antagonists in the setting of COVID-19 unless it's done on grounds independent of the virus, such as shock, hemodynamic instability, etc. You may have noticed that I sound sort of like a broken record, and I've mentioned multiple times over and over in the course of these slides that we really need pragmatic, randomized controlled trials for all of these drugs. These trials should not only just use viral load as an endpoint, but also clinical endpoints, because we know that viremia alone isn't the only way that this disease can kill. There's also this hyperimmune inflammatory response that can run amok and contribute to multi-organ failure and mortality. And this brings me back to this paradigm presented by Dr. Siddiqui and Mehra, published in the Journal of Heart-Lung Transplant, which we explored in part 1 of this talk. As it relates to therapies, we have to ask ourselves, what's the appropriate timing for therapies? At what stage is one therapy going to help the patient the most? And at what stage might these therapies be potentially harmful or not helpful at all? I think this is a useful paradigm to keep in the back of our minds as we study these therapies and think about prescribing them in this data-free zone that we have currently. And at the same time, we also need to continue to refine our understanding of this natural history of the disease and of the pathobiology of the disease, particularly in severe cases. To summarize, beyond supportive care, treatments for COVID-19 infection that are currently under investigation include steroids and immune modulators, antivirals, and other agents. These drugs can have important cardiovascular side effects, and this may not always prohibit use, but we have to be able to recognize them. We need pragmatic randomized controlled trials to make conclusions about any of these drugs, and remember that appropriate therapies might depend on the stage of illness. Thanks for listening, and I hope you're better able to understand the ways that the cardiovascular system may play a bigger role than previously thought when it comes to these severe cases of COVID-19. It's a trying time for everyone right now, and if you're like me and like to deal with these scary unknowns by intellectualizing them, then I hope these talks were helpful in distilling the COVID-19 literature to date as it relates to myocardial injury and therapies. I'd like to thank Dr. Joanne Lindenfeld and Dr. Javed Moslehi for reviewing the content of this talk. Dr. Lindenfeld is the director of the Advanced Heart Failure and Transplant Cardiology program here at Vanderbilt. She is one of my primary mentors and most incredible supporters. Dr. Moslehi is the director of the Cardio-Oncology program here, and between the two of them, I have learned so much over the last 3 years and am so grateful to have worked with them. I'd also like to thank everyone else at Vanderbilt and my co-fellows who are incredible, as well as the CardioNerds for producing such an incredible platform for disseminating information and discussion on the most relevant cardiology topics. Lastly, I'd like to thank the American Heart Association.